presented by SAMHSA's GAIN Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Today's event is the Future of Teleservices in Drug Courts Virtual Learning Community Part 3. And today we will be focusing on implementing teleservices for court proceedings and substance use disorders treatment. Next slide. I'm Erica Ihara, and I am a project associate at SAMHSA's GAIN Center and Policy Research Associates, and I will be covering some housekeeping items before the presentation start. So first, our disclaimer: the views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. So if you have questions for the presenters, we will be queuing up all of your questions that you submit and addressing as many of those as possible during the second hour of today's event. So we do encourage you to use the Q&A pod, which is located on the right of your screen, to type in your questions. And we welcome hearing from you. Also, to let you know, we will be conducting a couple of polls, and we do appreciate your participation in these. So when you see a poll pop up on your screen, if you'd like to participate, please go ahead and do that, and we appreciate hearing from you. This webinar is being recorded, and slides will be disseminated via the GAIN's listserv following the webinar. We will also notify you when the webinar recording is posted to SAMHSA's YouTube channel, and a certificate of attendance will be available for download at the end of the webinar, so after the first hour. And we just like to remind everyone that this is for personal portfolio use only. It is not a certificate for CEU credits. We have ASL interpretation for this event, and to view the interpreters, go to Layout in the upper right-hand corner of your screen, select Hide Non-Video Participants, and change the layout view to full screen, and then finally select View All. And we have two interpreters today. They are Jason Farr and Marika Larson. There is also live captioning for this event. To view the live captioning, select the Accept button in the multimedia pod, which is in the lower right part of your screen. The color contrast can be adjusted as needed, and we recommend a high contrast style for best visibility. So today we would like to welcome you to part 3 of the virtual learning community on the future of teleservices, and I'd like to remind folks you can please consult SAMHSA's YouTube channel where parts 1 and 2 and 3 will be posted in the future. So next, I would like to introduce today's agenda. So coming up next, John Berg will give some comments from SAMHSA, and then the presentations will follow, and then we will have an hour discussion group. So now I would like to turn this over to Mr. John Berg. He is Senior Public Health Advisor at the Center for Substance Abuse Treatment at SAMHSA, and he is going to provide some opening remarks. John?
Thank you, Erica. I appreciate it. Welcome, everyone, to today's Virtual Learning Community, or VLC, the Future of Teleservices in Drug Courts, Part 3. Implementing teleservices for court proceedings and substance use disorders treatment. We appreciate you taking time out of your busy schedules to participate today. As I have noted in previously in the series, the opioid crisis continues to be a public health crisis with devastating consequences, including increases in opioid misuse and related overdoses. Unfortunately, we saw record numbers of overdose deaths over the past year. The impact of the COVID-19 pandemic continues to negatively impact drug court programs and their ability to serve clients. While treatment drug court programs had to incorporate technology and teleservices into programming during COVID-19, there are ongoing issues related to implementation and the need to identify best practices as we continue to move through the pandemic. SAMHSA is invested in assisting drug courts and other criminal justice-related programs such as reentry programs to deliver services more effectively to participants in these programs. As we have learned over the past months, teleservices is a promising practice to positively impact the criminal justice field by increasing the capacity of the justice system to respond to the pandemic and to the opioid crisis. The effective use of teleservices increases access to MAT to reduce opioid relapse and overdose, and assist drug court and reentry programs to develop more efficient service delivery to program participants. Part one of this three-part VLC presented a retrospective view of the transition to teleservices from the perspective of treatment court practitioners, a review of the mounting evidence base for teleservices in treatment court settings, and commentary on the potential for enhancing best practice standards through the use of teleservices. Also, results of a nationwide survey of treatment courts regarding practice modifications, implementation barriers, effective innovations, and intent to continue use of teleservices was presented. Part two of this VLC reviewed the many considerations for treatment court practitioners to address as they plan for adoption or more permanent expansion of teleservices, including assessment of organizational readiness and fit, assessment of client readiness and fit, and staff and client training needs. Today in part three, we will provide detailed guidance on the many considerations for effective implementation of treatment court services delivered in virtual formats, including both court proceedings and treatment services. Our presenters will feature a brief review of essential service elements, policies and procedures necessary to support effective delivery, strategies for ongoing quality assurance that will inform necessary refinements, and suggestions for tracking appropriate outcomes. We are pleased today to host today's VLC with 4 experts in the criminal justice field. Our presenters for today are Rebecca Provost Emmons and Susan Sturgis. And joining our discussion panel again are Dr. Michael Chappell and Victor Vasquez III. Thank you, presenters, for sharing your knowledge and expertise again with us today. And thanks again for the Gain Center staff and their work in developing this VLC. At this time, I'll turn it back to you, Erica.
Thank you, John. And now it is my pleasure to introduce our panel to you all today. Ms. Rebecca Provost Emmons is Director of Criminal Justice Services for the Tennessee Department of Mental Health and Substance Abuse Services, and she has also served as a recovery court administrator in the state of Tennessee. And in her current position, she oversees a wide array of services for people who are involved with the criminal justice system and works in partnership with judges, courts, and treatment providers. Next slide. Ms. Susan Sturgis is statewide opioid court project director for the New York State Office of Court Administration, Office for Justice Initiatives in the Division of Policy and Planning, and she has worked previously as the project director of the Brooklyn Treatment Court in New York State. Dr. Michael Chappell is assistant professor of clinical psychiatry at the New York State Psychiatric Institute at Columbia University. He leads SAMHSA training and technical assistance initiatives for HHS Region 2, and that includes the Addiction Technology Transfer Center and the Opioid Response Network. And Mr. Victor Vasquez is director of the Webb County Court at Law DWI program in Webb County, Texas. Prior to becoming director, he served as a case manager for the DWI court. And I just want to remind everyone out in the audience, so we will be hearing from Rebecca and Susan in the first hour. And during the second hour, Mike and Victor will be joining us for the discussion to follow. So just before I turn it over to our presenters today, I'd like to share a little bit of information about our audience. So thank you to everyone who replied to the poll. Most of you are calling in today from urban locations, followed by rural and then suburban in the smallest group today. We have folks who work in the judiciary, probation, parole, corrections, policy, community-based organizations, and hospitals and government and other. So thank you to everyone who is out there in the audience, and we look forward to hearing your questions. So please, throughout the event, feel free to type in your questions in the Q&A pod, And I am going to turn this over now to Rebecca Provost Emmons to begin the presentations.
Thank you, Erica. Hi, everyone. As we've touched on, I know in some of the previous slides or previous presentations, this has really been a year and a half of adapting and overcoming. And I can speak for my state of Tennessee when I look to my treatment courts, my drug courts, my recovery courts, the creativity and the resilience and the adaptability has just blown me away. So I'm excited to be here to talk through with you all some of the things to consider when we start to think about what it looks like moving forward, what it looks like now, what it looks like next month versus what it looked like last month. But some very important concrete things that we can actually go ahead and discuss and decide and think about to kind of set treatment courts up to be able to navigate our new landscape. I think we can all agree that our new landscape was abrupt, and we had to figure out ways to adapt pretty quickly. But it's been a year and a half now, and we're not sure how much longer it will be. But some of the things that we've implemented, we need to start looking at how to either make permanent, what's going to stay, what's going to go, and really trying to set some parameters around what we're doing, particularly as it relates to treatment court operations in our new world. There's three things that really should guide us as we begin to think through treatment courts operating. We need to think through procedural fairness. And for those involved with treatment courts, I know we understand this concept. We need to clearly communicate with our participants, with our team members. We need to have streamlined process that is laid out simply and gives them the ability to be compliant and to maintain compliance. We need to ensure that everyone has the same access to justice. Are we offering virtual options to everyone, to certain participants, to certain phases? What does that look like for us? We also need to ensure that there's accessibility of services, that our clients understand how to access them, and if there are challenges, how we can walk them through that process, come alongside our participants and help them navigate this new world that's new for, not as new now, but still new for us and them as well. Those involved with treatment courts certainly understand the importance of laying the groundwork. Policies and procedure manuals are the foundation for our recovery courts. Participants need to know the parameters, they need to know the rules, they need to know what's asked of them. So when we think through laying the groundwork, are we going to adapt everything to a virtual world? Is it just going to be team meetings? Is it going to be court sessions? Is it going to be some court sessions for some participants? How are we going to determine what that looks like? We need to think through all of those. What platform will we use to deliver these? How will the clients access the services? But in thinking through, we also need to make sure the rules are simple and understandable, and that we are able to provide that communication to everyone in the way that's needed. Something too that I would also think through is when you do establish these policies and procedures, is it going to be standalone, or is this going to be something that you're going to fold into and incorporate into your current practices, policies, and procedures? So when you think through virtual world with recovery court, there's several things to consider. And I know you all have probably experienced all three of these: in-person, hybrid, and virtual services over the past year and a half. We need to determine as we move forward, or as we need to pull back, depending upon where we are currently or in the future, need to determine which services can be offered virtually, which can be hybrid, and what needs to be in person. As such, any procedures that we establish need to be flexible and accommodate clients who either can't or prefer not to engage in services virtually. And I think that will depend upon the population of your treatment court, what it looks like for a drug treatment court versus a mental health court versus a juvenile drug court is all very, very different. And you need to be thinking of those things. Also, we need to ensure that everyone has equal access to justice. When we're setting up the schedule for court, is it all in person on certain days, all remote on certain days, always hybrid? Does it depend upon whether or not our clients have transportation, if it involves them having to take time off work? And particularly as a parent in the summertime, what does childcare look like? All things that we need to think through. Another extremely important part of thinking through virtual versus in person is the technology infrastructure. I know, this time last year and even prior to, there was a lot of folks scrambling to set up, what does Teleservices system look like? What is my Wi-Fi capacity? Do I have a projector? Do I have a monitor big enough to accommodate the courtroom? Do I have a microphone? An example of this, as I set up my own virtual office during this time, was my kids are into gaming and they have the microphone set up and they have the multiple monitors, and they became my IT support and helping me get everything set up. So does your court have an IT person available? Does your jurisdiction have an IT person available? Or, as it works in treatment court, sometimes are you the designated technology person? You need to consider who will run your IT or your speed test for your internet, what that looks like. Just a lot of considerations, and many of you may or may not have a support person to help with this. So it may end up being you, lucky you. Another very, very important part of this is we need to think through, what does the docketing and scheduling look like? If we're talking about hybrid, do we need to consider how large the docket is, how many folks will be in the courtroom, if there's designated waiting space for them? We need to ensure that we provide instructions on how to access that. As an example, I know, we've all gotten used to some of these virtual platforms, but what does the WebEx platform look like versus the Zoom platform versus the Teams platform? How do we communicate with those attending and participating, what that looks like? We're lucky enough on this presentation to have Erica helping us with all of those things, but who's that person in the court that's going to help do that? How are we going to communicate? I know pre-COVID, individuals would show up to court, and I know some courtrooms would have, here's a list of things you can and can't bring into the courtroom. Here is a list of here's kind of a dress code, what you should and should not have on. How do we communicate that with participants now? Maybe there's not a central location where they can go and get that information. Also, how do we support participants who may not have technology? I know for some of our courts here in Tennessee, we've had participants that didn't have a smartphone, might not be able to access court virtually. So do you have funding, or are you able to secure funding or access grants or other assistance that will allow participants to gain access through tablets or maybe Wi-Fi hotspots? All things that need to be considered. I touched on this earlier just briefly, but we need to think about, what does the space look like? I've seen some courts that have the giant TV that's on the little robot body that can respond when someone speaks. does your court have that technology? If not, how do you set it up so that those who are attending, if you're doing a hybrid model, those who are attending virtually can interact and participate with those who are attending in person? You need to consider physical space. Is privacy required? How will that be handled? For those attending, do they have a private space? How will that be handled? Are individuals, like I was speaking to on the previous slide, when someone comes to court, sometimes they can look on that door and see clear cut, but are folks instructed on what's your role in this virtual world? I'll use an example from this presentation. Before we came on, I was asking Erica about some technical aspects. When do I turn my camera on? When do I turn my camera off? Do I have to turn my camera on? Am I going to be muted when I enter the space? Will someone mute me? All things that we need to communicate and make sure that all those participating, not just those participants, but everyone on the team understands what that looks like. Another very, very important area for consideration is how will you make ADA accommodations for those with hearing impaired, sight impaired. We have, how will you provide that availability to them through electronic means? And how will you ensure that those who are in person versus virtual have the same access? It'll be really important to address this in your policies and procedures as you develop them. And that is an area you may already have some information in your policies and procedures as it relates to this, but specifically when we're talking about virtual, how does it change? How do those look a little bit different, or maybe they don't? But this should always be at the forefront when planning what this looks like for you. Another question to ask or something to consider is, as we transition to more in-person or transition back to more virtual and then back to in-person, whatever that ebb and flow is going to look like, what things would you like to keep virtual? I've heard anecdotally from some of our programs here that for clients that are in a certain phase, maybe they'll get to come virtually from here on out. Clients that have a certain kind of job. Are we going to allow that hybrid model and or have hybrid every other month? Are we going to keep video arraignments virtual? I know a lot of courts had been doing that previously. Are we going to do home checks moving forward virtually, whether it be through a platform or another means? Court staffing. I've heard from a number of our courts that sometimes team members who were geographically or unable to attend staffing meeting weren't able to come. But now, is everyone going to be able to attend regardless of where they are? I know in Tennessee, our judicial districts can be large. I know the same for my colleague here in Texas that is on the call. Their jurisdictions can be very large. Are we going to be able to kind of close the gap for some of these things? Remote drug testing. Is that something that we want to consider? And or graduation ceremonies. And I can tell you just anecdotally from personal experience, a remote treatment graduation ceremony, albeit is amazing. The in-person ones for me are definitely the way to go, and I was excited to get to attend one last month. All right. As we consider adopting virtual services, or as you consider all of the items we've touched on as it relates to virtual services in your court, we have to keep in mind that everyone's different, and maybe something's worked for you and hasn't worked for another court. Are you rural? Are you urban? What's your Wi-Fi signal like? What's your cell phone signal like? All of these things to keep in mind. And I think this is also a good time when we look to our, courts across the state. I know we're great at networking with each other. So begin the dialogue. What have you learned? What can you share? What have other courts learned that they can share? We can't forget to also include our clients in this conversation. Survey your clients, have a focus group, virtually or in person. Ask them, what works for you? What do you like? What do you want to keep? What do you not want to keep? What's your preference? I think that getting their feedback is crucial in continuing to maintain their engagement and ensure that they're actually receiving good quality care from us. Maybe consider developing a flexible program. Are we going to have hybrid forever and ever? Is this something we're just going to move into with the future? Again, we talked about what things you would want to keep as virtual, what things you might want to have as in person, and how you need to address those clients that have technology challenges or those who just simply prefer in person. Speaking for myself, I enjoy in person. I enjoy the opportunity to connect. And those relationships and connections are so very important to our clients in this process. So always need to keep that in mind. When we've talked about this, and anytime we talk about recovery courts, we need to be sure we have clear written guidance. We need protocols. Folks need to be reminded, hey, remember, when you attend court, this is how it needs to be. We need to have it easily accessible, and we need to have it uniform so that there's guidance for them as they move forward. And I think this next bullet cannot be overstated, because as we move forward, we need to continually do course corrections. If something's not working, or if your clients are telling you something's not effective as it relates to virtual services, what can we do to change? Who makes that decision? Is that a team decision? And what does that look like for your program? So being flexible and understanding that the policies and procedures that you're maybe either have now or working towards, as I say, is a living and breathing document. As we navigate and figure out what works best for you and your program, always be open to changes and improvements that will help improve the experience not only for your participants, but for your entire team. And so with that, I'm going to turn it over to Susan. And I thank you for your time and attendance, and I look forward to discussion later on as we continue. Thank you.
Thank you, Rebecca, and good afternoon or good morning, depending on where you're joining us from. My name is Susan Sturgis, and I'm the statewide director of opioid courts for the New York State Unified Court System within the Division of Policy and Planning. And I really appreciate everyone joining today's session, which Erica said is the last of three, focusing on teleservices and drug courts. And the previous sessions were really informative. So hopefully I can live up to those expectations and standards and close us out here. I'm going to be discussing how teleservices can be used for the delivery of treatment and recovery support services, but really with an eye towards ways in which we can blend the best of both in-person and virtual operations as this world keeps evolving and things keep changing. So, we've just heard a great presentation from Rebecca on the use of teleservices for court proceedings, and I'm just going to shift the focus a little bit for the use to the use of teleservices for the provision of substance use disorder treatment. And for the purposes of today's discussion, I've broken that down into three different categories, starting with psychosocial counseling, medication-assisted treatment, or MAT, and peer and other recovery support services. Now, within the scope of treatment, teleservices can be used for many things, but really, screening and assessment, individual and group sessions, evidence-based treatment delivery, and supportive services and continuing care. And there are many benefits to using teleservices for the delivery of treatment. And I'm sure you've heard these before, and I know they've been discussed in other sessions, and some of them might be a little bit obvious, but I did want to reiterate them today and suggest that these benefits shouldn't be overlooked as restrictions begin to be lifted and we move back towards some in-person activities. And some of these benefits you may want to consider and may contribute to the justification of some sort of hybrid model as we move forward. I think, most notably using teleservices helps overcome barriers to treatment, that is without a doubt, and it makes treatment more accessible for people. And we want to take that into consideration as we explore ways to blend both delivery options. Teleservices also help expand provider capacity and really improves access to treatment, but particularly specialty services that can be hard to come by in certain areas. So it can be easy for people to connect in where there's specialty services where they might have to travel a far distance or just might not be available in their area. And it also saves travel time and money, especially in rural areas where transportation can be quite costly and pretty challenging. Going to a 1-hour treatment session can take the majority of a person's day sometimes in some rural areas. It also provides flexibility for providers and participants. And this really allows people to work treatment into their schedules and not the other way around. Sometimes people have to work their entire schedule around a treatment session. But when we're using virtual services, we can help people retain employment by maybe, allowing them to fit treatment in where they wouldn't have to factor in the associated travel time. People wouldn't have to leave early at work or show up late just to fit in their treatment session. Treatment becomes much more practical for people, and they can fit it in a lot easier. And so many of these benefits have made the delivery of treatment much more affordable, but also practical, and which in turn might help people, retain people in treatment. When treatment fits easier into someone's life, they may be more inclined to stick with it and stay at it. So a few things to consider when using teleservices for treatment, and especially as you're continuing to use these services beyond COVID. One of the things that I want to talk about was you want to allow time and patience when developing your therapeutic alliance. This is really important. Don't get frustrated. As some clinicians have said, it's frustrating, but it will develop over time. And there is evidence to suggest that being present in the room with a client isn't necessary for building that strong therapeutic relationship or therapeutic alliance that we're used to. But there are some things to consider to help build that and to help promote that strong therapeutic alliance. And one of those is you want to be patient with how things develop. You want to let it develop organically and naturally in its own time. And you want to make sure that you're comfortable with the technology you're using. Make sure you've tested it out and feel confident in whichever platform you're using for your treatment sessions. And it's really important to establish a video presence. So you want to turn that camera on and make sure you're appearing clearly to the participant or your client. So you might want to consider your lighting, your seating, maybe the camera position. Check your filters to make sure you're not coming through as a cat. I think we've all probably seen and had a really good laugh at the lawyer cat video that's gone viral. But the point is here, you want to appear as the professional that you are. So take some time to check your filters, check your settings, check and double check, maybe devote a few minutes to log in early to make sure that everything's right. So you're going to appear as a professional in your session with your client. Also, audio is really important here. You want to make sure you can hear and be heard clearly. And while operating remotely isn't necessarily new for us anymore, it may not be, it may still be new for our participants. And so you want to prepare them for what this remote telehealth environment looks like. You want to explain what they can expect from engaging in this treatment, in this form of treatment, since it's new to them. We don't want to assume that they're comfortable or familiar with technology or this remote process. For some of our participants, just entering treatment, that experience is new. So entering treatment in a virtual world is really new and might lead them to be hesitant. And so we want to make sure that we're communicating and educating them. That goes a long way here. And also, this is where patience comes in again too. Your first session or two, you might spend quite a bit of time just helping your participants or your clients get acclimated to this process, and that is okay. It's all part of building that therapeutic relationship, and it will actually lend itself to a stronger alliance over time. So you also want to consider establishing clear guidelines and expectations for clients participating in virtual treatment. Just as the program set expectations for in-person groups, where there's that group code of conduct, the same holds true for virtual groups. And you just want to remind folks about this and remind them that this is still treatment, and explain or reiterate the rules and how they may apply differently or uniquely to virtual sessions. Some things important to establish are expectations regarding appropriate dress. You want to be sure that people are fully clothed or appropriately clothed. I know this might seem like common sense, but I have some stories that I could share. I'm sure you've all have seen some stuff. But let's just say that while it seems like common sense, it's not and should really be elaborated upon, and rules should be established. Location is also really important for many reasons. Obviously their location can be a distraction for them or others participating in treatment, but it also lends itself to confidentiality issues. You don't want clients participating in a session, where they're in public and the group can be heard or seen by others. And I'll talk more about this in just a minute. But really for location, I've seen clients participate in a treatment session, while they're working as a cashier at a bodega, actively selling beers to somebody, standing in front of a wall full of spice and K2 packets, among other really highly inappropriate items. So obviously not the best choice to participate in a treatment session from that location, not what we want to be exposing the group to, and not the most conducive treatment environment. So these are things you want to address. And you also want to be sure you're setting, clear guidelines for what it means to meaningfully engage in virtual treatment. It's not just showing up and turning your camera off and sitting through that. You want to talk about what it means to participate and pay attention and be respectful to others. So maybe muting themselves when not speaking, or developing some mechanism for, identifying that they want to speak, like raising your hand or other functions. But it's also really important to address that multitasking. I know that we probably all do it. Many of you are probably multitasking right now while you're listening to this presentation. We're all guilty of it. But in groups, in person, there are rules about checking your phone and doing other things while you're in group. And so we want to be sure that we set those expectations for virtual groups, because we really want people to engage in treatment, even if it is virtual. And so you want to make sure that people know what it means to engage meaningfully, that they should limit multitasking, that they really shouldn't be joining the session from their shift at work. Like in my example, they shouldn't be driving or walking down the street or even riding the subway. It really should be one stationary place that's relatively private, so they can focus on their treatment for the duration of the session. So one of the things I touched on a few times, but I really kind of want to dig in now, is to talk about consent and confidentiality. And so when engaging in virtual treatment services, it's really important to obtain the participants' consent. They should be agreeing to participate in virtual counseling, whether it's group or individual sessions. We want them to consent to participate. You want to be sure that the participants are comfortable with this method of engaging in treatment services, and that they're agreeable to participate. Consent isn't something that should only be addressed once. It should be repeatedly addressed and discussed with participants, because really their consent can change at any time. They can opt out of virtual services at any time if they're no longer comfortable. And so this is a really important consideration as we move forward into hybrid models, because you want to be sure that consent is reviewed at each session. In the beginning of this, when the pandemic first started and stay-at-home orders were issued, it really prevented any in-person activities. So there really was no choice. Virtual was the only option we had. But now as we shift back, it's important to really discuss with participants what their options are for attending treatment, and provide them with some level of choice, and more importantly, obtain consent for that. And similarly, privacy and confidentiality considerations should be addressed and explained to clients repeatedly, especially given the unique context of virtual treatment. And so this is a conversation you want to have over and over again with participants. When holding groups in person, that physical space is said to be, that safe space, and what's said in group stays in group. All of those group rules apply to protect people's privacy. And this can really be put to the test in a virtual group session, because participants are in various locations, and it is possible for confidentiality to be compromised if other people who are not in the group can see or hear the session. So there are some concerns. So it's really important that we explain this to participants, that we have these conversations at the outset, but also that we review it at the beginning of each session. So it's constantly reminded that we need to protect everyone's privacy. It's important to explain, ways in which we can protect privacy, ask people to, commit to ensuring that no one outside the group can see or hear the group session. And this may be challenging for some participants because they might not necessarily have private space in their home to do group. And so it's important that we work with each individual on a case-by-case basis to help, troubleshoot some of these issues and brainstorm ways that will allow them to participate in the group sessions while preserving their own and everyone else's confidentiality and privacy. So another thing to consider, which I just want to touch on, is communication with stakeholders. As we move into this virtual world and maybe some sort of hybrid world, it's important to communicate with the court teams and the court stakeholders, what virtual treatment is, what are your practices, and, what is the structure for that? What are the participant expectations for that? How will they be monitored, what their schedules are. The court team is made up of a lot of different players and they have a lot of different priorities. And so you want to make sure you're addressing each of those appropriately. Defense counsel might have concerns about confidentiality and privacy, while public defender's office might have concerns about meaningful engagement. And so, as we're developing this model and it takes shape into some sort of blended model, you want to make sure you're addressing everyone's concerns. And so virtual treatment can take shape in a lot of ways. It can be psychoeducational groups, process groups, individual sessions. And I just wanted to highlight a few examples of some evidence-based treatment that can be conducted virtually, and that kind of translates to the virtual world really well. The first one is interactive journaling. And this is a goal-directed, client-centered model that really aims to reduce substance use and related behaviors. And it does so by guiding participants through a process of written self-reflection. And clinicians that I've worked with have expressed that, interactive journaling has been really helpful in getting started with virtual individual sessions in particular. When programs switched over to virtual sessions, it was new for everybody, and it wasn't uncommon for there to be some like dead air, and I'm sure it's still not uncommon for there to be some dead air during sessions where there's just silence and you hear the crickets. But clinicians reported that using IJ helped guide the session. The journal prompts helped the clients open up more. It gave them talking points, and it also allowed for clients to continue their work outside the session, which was really nice. Similarly, moral recognition therapy, which I'm sure many of you on this call are familiar with, so I don't really need to get into it too much, but it's another form of therapy that can easily be conducted virtually, whether it's phone or through video. But MRT, seeks to improve moral reasoning and decision-making, and it guides participants through various steps, and there's homework assignments, so it kind of continues the work outside the session again, which is nice. But it helps direct sessions and provides some framework and structure for therapy sessions. And now CBT for CBT, I wanted to mention because it's totally different from the other two, in that it's an asynchronous web-based therapeutic intervention. And so it's self-guided and it utilizes interactive tools and exercises to teach participants skills for reducing substance use. It's about 7 to 9 modules, and it can be integrated into participants' treatment plans. And it really reinforces skill building that they're likely doing in session with a clinician during individual sessions. So it ranges in format. I mean, it really tries to keep participants engaged since it is asynchronous. They really use a lot of multimedia like games, videos, audio, interactive assessments. Really helps keep people engaged because they can work at their own pace and complete the exercises when it's convenient for them. And this was developed by researchers and clinicians at Yale University, and there actually have been some randomized clinical trials, and that data suggests that it is effective in improving substance use outcomes, and that it can be appropriate for a wide range of individuals, including those with comorbid mental health disorders. So it may be a good option to begin to check out for participants. So I want to, now move into using teleservices for medication-assisted treatment, or MAT. I think we all know and we've all seen that the opioid epidemic was exacerbated by the COVID-19 pandemic. And there's some stats on this slide, and these slides were actually done several months ago. But the one here is that the Commonwealth researchers estimated that the total overdose deaths for 2020 could exceed 90,000. And sadly, this estimate, turned out to be accurate, because last week the CDC released data indicating that 93,000 people died from an overdose in 2020. And that's a 29% increase from 2019. And every state in the country saw a significant increase. I mean, these numbers are record breaking, and it translates to an average of 250 deaths per day, which is just shocking. And really, the synthetic opioids that are being found in stimulants and other drugs are the main driver behind these overdose deaths. And sadly, like, we could talk about this all day long, but I'm just going to leave it at that for now. So this is not just my opinion. This is the position of the American Medical Association, American Society for Addiction Medicine, and American Academy of Addiction Psychiatry, that medication-assisted treatment is now the standard of care for treatment of an opioid use disorder when used in combination with other counseling and behavioral therapies. As everyone on this call, I'm sure, knows, it reduces cravings, enhances treatment engagement, and save lives. So fortunately, the U.S. Department of Justice and Department of Health and Human Services enhanced the flexibility for practitioners to prescribe buprenorphine using telehealth services during the pandemic. And so some of these key policy changes to enhance access to MAT are that the initial evaluations can be completed remotely via telehealth, and that includes both phone and video. Providers can induce participants virtually and maintain those who are already prescribed. And that once prescribed that medication, participants can pick it up at the pharmacy and begin home induction. So while regulations have been relaxed when it comes to the prescription of buprenorphine, as we move into hybrid models, it's important that all 3 FDA-approved medications for the treatment of opioid use disorder are offered to clients, and that the decision should really be theirs to make in consultation with their physician, considering the relative clinical advantage that I have listed here. So when considering virtual MAT evaluation and induction, education is key. It's really important to be sure that the client is educated on the medication, the induction practices, and the overdose risks. Verbal and written instructions should be given for home induction. I have a snapshot here. I'm sure it's hard to read, but these are just an example of some worksheets that are provided to clients, and there's several examples out there, but these worksheets really describe in writing and in a flow chart form how to begin the induction, how to take the medication, what symptoms they may be experiencing, and how to continue their dosing based on those symptoms. So it really is a step-by-step, very helpful guide for participants to follow for home induction. One of the things to consider when using teleservices for MAT is that it can be limiting in terms of toxicology testing. So I'm sure many of you know a urine drug screen should be obtained as soon as feasible following that initial evaluation, but that the absence of a drug screen shouldn't delay induction on buprenorphine. But now that in-person restrictions are being lifted, and it seems to become easier and easier to obtain a urine drug screen, so providers can work it out with their patients and how frequently they need to appear to get that drug test to confirm adherence to the MAT, and really develop some type of blended model that incorporates in-person visits with virtual visits. Some other things to consider for virtual MAT is, how long that prescription should be given before a reevaluation is necessary. Sometimes at the outset, it's just 1 to 2 weeks to make sure somebody is doing okay. Also consider co-prescribing naloxone and providing training to both the patient and the family, and really just integrating MAT into a collaborative behavioral health care plan. It should just be one piece of the puzzle, and ensuring that the participant has support from the entire treatment team, which is not only the prescriber, but the clinician, the court staff, and the peer. And so when thinking about and considering how to incorporate virtual MAT either now or beyond COVID, and maybe as the world keeps changing and there's variants out there and we may open back up and shut back down. It's important to consider a hybrid plan, and so I have a few examples here for virtual clinics and virtual telemedicine providers. I have Caden Health and Bright Heart Health, and these are just two examples of virtual clinics. But both of these provide virtual MAT evaluations, induction, maintenance, along with group and individual counseling sessions. They usually require a toxicology sample, once or twice a month. And these clinics are really new and emerging. And these are just two examples. They're more and more being developed and launching as we speak. And actually insurance coverage is kind of catching up and expanding coverage for the use of these services. So I'm sure we'll begin to see more and more pop up. But it's also really important to build relationships with your community providers, so your OTPs, your waivered physicians, your substance abuse treatment providers, and work with them on developing a protocol for virtual MAT services that makes sense for your clients and the court. And really, one of the most important elements is ensuring that your participants have access to a secure connection to be able to participate in this virtual MAT. So maybe explore funding for providing clients with tablets and phones or other devices, either for use at home or in the courthouse, so that they can connect into these MAT evaluations or other treatment services. There's a lot of grant funding out there that you might be able to obtain to help with those resources. And an example of one of the smartphones, CoreSoft, is a great example of a smartphone-based solution that really helps engage participants, support them, and monitor them. And their programming that CoreSoft has really makes the treatment connection and engagement easy and fast. So that's just one option. And so finally, I just want to spend the last bit of time talking about how we can use teleservices for peer support and other recovery support services. I think peers and recovery supports are such an important piece of the treatment plan, and one of the pieces that can really be enhanced by the use of technology long-term, especially beyond the pandemic restrictions. So just like teleservices can be used for the delivery of substance use treatment, it can be used much in the same way for peers who deliver individual coaching, group coaching sessions, who conduct recovery capital assessments and wellness plans. All of those activities can very easily be conducted through video or telephone connection. And another really valuable tool that grew out of the pandemic-related restrictions are the virtual support groups and those mutual aid meetings. Luckily, many organizations quickly shifted to a virtual model, providing people with a safe virtual space to continue to share and receive support. And for many of our folks, these meetings are a critical piece for them in their recovery process. So having the ability to access them virtually really allowed them to stay connected and feel less isolated during COVID and during these challenging times. And just anecdotally, I also heard from many people that the ability to join these meetings virtually helped those who may have been kind of hesitant or on the fence to attend those meetings in person. So some people had anxiety about going to those meetings, but being able to join virtually kind of took the pressure off a little bit and allowed them to join these meetings virtually. And it really opened up some doors and some opportunities for people in their recovery journey that they hadn't explored before. So that's pretty wonderful. And then, of course, there are the recovery apps that are out there. Some of them have been out for quite some time, and others have just emerged because of the pandemic. But I think based on the success people have had with these apps and some of the support they've received, these will be some of the elements of people's recovery that stick around for quite some time because they provide support in a fast and convenient way. And I'll talk about some of those in just a minute. But I did want to touch on one of the considerations for peer support in a virtual world. I just want to touch on it briefly because I think it's worth mentioning that it's important that we are providing our peers with the necessary technology to do their work, but then training them on that technology. So we want to make sure that they are comfortable with the technology, how to use it, and we want to help them settle into this new environment and the role that they're going to be playing virtually. Working in this virtual world is new for all of us. And so since we haven't done it before, there are a lot of issues that arise and a lot of things that need to be discussed and sorted out. And as we've been doing this now for like, I think 16 months or so, there's still some anomalies and situations that arise that are confusing. And so it's important to have that continual education and communication and really just regular supervision sessions where you can discuss boundaries and clearly define the roles and responsibilities as it relates to their virtual work. And I think, this is really applicable for all of us in the field. When stay-at-home orders were first implemented, I know many of us were really worried about our clients and their well-being. And none of us had really worked from home in this capacity before. So it was easy to work way beyond your typical workday. There was so much to get done and to adjust to the new way of working. And our concern for our clients also often led to, really exhaustive days and sometimes nights. And I know I had to have many conversations with staff where we discussed that working from home didn't mean working every day, every day or every minute of the day. We still needed to set boundaries and take time for ourselves and practice self-care. And so while that's important for everybody, it's really important that we get that message across to the peer staff because you want them to feel supported. Peers play a really critical role for our participants, and they're so valuable to the team that it's important that, that we're debriefing with them after sessions, that they're processing things with supervisors, and that there's a space for feedback, encouragement and support in this virtual environment. So with that being said, here's some examples of some virtual peer recovery supports that have been successful. And we've kind of seen this through, practice-based evidence, but peer-led psychoeducational groups. Some peers are leading, relapse prevention groups, wellness groups, facilitating MRT or IJ if they're trained. Some programs have also developed peer-organized virtual social meetups, which have been wonderful. So virtual yoga, meditation, book clubs, game nights. And I really hope some version of these stick around because they've really been such a wonderful outlet for clients. And peers have also been amazing at helping, connect our participants to virtual recovery supports and other resources. And a few examples are, the recovery community organizations, so those RCOs, Faces and Voices of Recovery is a great clearinghouse to find information about RCOs, and they also have an extensive mutual aid resource list. And many of our participants have experienced mental health symptoms during the pandemic, and many of the peers have been able to connect our participants to some mental health resources for free. And so the livewellfoundation.org is a wonderful organization. They provide virtual peer support. They provide skill-based education for those experiencing mental health symptoms. And the program is really meant to provide support from peers and to teach skills to reduce symptoms and just increase general feelings of well-being. And also the UCLA Health Mindfulness Research Center is a free app that can be downloaded on any smartphone. And it provides guided meditations as well as mindfulness tips and podcasts really aimed at reducing stress and symptomatology. And this one's available in both English and Spanish, which is wonderful. And another app worth mentioning is the Chest Connections app. It's another great tool that's more treatment focused, but it provides connections to providers and peers. And it has a virtual e-therapy section, which is a modified CBT for CBT program for that specific app. So some wonderful resources. And then here I have a list of some of the mutual aid resources that offer virtual groups. So We Connect is an online resource that offers substance abuse counseling, but they also offer free support groups to anyone that downloads the app. And so these groups are peer-led and they're offered multiple times a day, and they're free to anyone downloading the app. Unity Recovery was, founded to be one of the most all-inclusive groups, and they offer 7 meetings a day with specialized meetings throughout the week for women. They have LGBTQ+ groups, pregnant and postpartum, and they also have a harm reduction workshop, which is really interesting. And finally, the other two, Smart Recovery, Refuge Recovery, I think these are more widely known, but they offer several meetings a day, as well as other virtual resources and some virtual retreats, which are pretty interesting. So I'm happy to say that these 4 are just the tip of the iceberg. There's so many, wonderful organizations that offer both in-person and now virtual supports. And I wanted to say that I have all of these resources because I've worked with some really incredible peers, clinicians, and case managers who really immerse themselves in this stuff. And so I just want to give a special thank you to Rebecca Bortline from the Brooklyn Treatment Court, who is a wealth of knowledge and really I have relied on for many, many years to keep me in the loop on all these wonderful resources. So just to wrap things up, some final thoughts here. You know, as we live in this virtual world, the longer we do it, the more we learn. And so it's really important to stay on top of the best practices because they're constantly evolving. So you want to make sure you're staying current and knowing, you know, what works and what doesn't work. And as we're hopefully coming out on the other side of this pandemic, you know, we can begin to get back to the way things used to be. But hopefully better, you know, because we can incorporate the elements of technology that worked well and enhance the treatment experience. You know, I know we kind of shifted into this virtual world because we were forced to. It was a crisis and we had no other option. But it doesn't mean that the technology is only to be used in crisis situation. You know, there have very clearly been some benefits to using technology, and it doesn't have to just go away because in-person operations are resuming. So it's important to take some time maybe within your organization and do an assessment and evaluate, you know, how technology has benefited your organization and your clients and see how those benefits can be maintained really through some type of flexible and blended model of care. Technology can be useful in helping ease participants back into in-person activities. I know I've seen all these articles and read these articles in the news and magazines about, you know, reentry anxiety, about how many of us either are experiencing or may experience anxiety related to returning to life beyond COVID and emerging from our homes and leaving home for the office or for, you know, every other day activities. And so this is important for our participants as well. Commuting and being in groups with many people, you know, may be stressful for many people. And so we want to consider this when developing treatment plans as restrictions lift. You know, just because in-person treatment may be happening again, it doesn't mean it's best for everybody, not full time, not right away. You know, you want to consider easing people back into treatment and by developing a hybrid plan wherever appropriate. And even beyond the transition, I think hybrid strategies are something to consider for all participants as we really try to incorporate, you know, what worked to enhance treatment services. But it's important to keep in mind that hybrid strategies may be appropriate for some, but not all. And I think that over time, you know, your organization can determine, you know, how those decisions are made, and it should really be made by the treatment team on a case-by-case basis. And finally, you know, hybrid treatment plans should be reviewed regularly to determine appropriateness and to see how folks are responding and to see if any adjustments need to be made. And so that wraps things up for me. I know I gave a very quick and brief kind of high-level overview of things. We have the Q&A coming up, but I just wanted to provide my contact information in case anyone wanted any more information on the resources I discussed, because I know I touched on them very, very quickly, or if there's any questions you wanted to reach out to ask. So I'll turn it back over to you, Erica.
Thank you, Susan. And I wanted to take a moment to thank both of our presenters, Rebecca Provost Emmons and Susan Sturgis. Thank you for those informative presentations. We have a number of questions queued up already for you and the others. I'm going to take a couple of minutes to walk folks through just the last of the admin items for today's events. So we have let you know there's a certificate of attendance for anyone who would like to download that. You should be seeing a file transfer box pop up on your screen in the next couple of moments. And we'll go ahead and do this maybe once or twice again during hour two. So if you missed the opportunity to download it here, you'll have another chance later on. Go ahead and if you'd like to download this, you can select the file name with your mouse, click once, and hit the download button, and that should start the process for saving the document to your computer. And just as a reminder, this is not for CEU credits, it's for your personal portfolio use only. And then I would like to share some information about some upcoming events we have. Here is a list of some additional webinars and another VLC. that we have. One is tomorrow, and then some more events in August and September. So we hope to see some of you there. And all of that information, how to register, is available on our Gaines listserv. So if you are not subscribed yet to the listserv, here is the address that you can sign up if you'd like to receive our mailings. And finally, our contact information here at SAMHSA's Gaines Center. If you would like to contact us regarding anything else, next slide, please. Please feel free to reach us here. And for those of you who would like to stay on the line, there's nothing you need to do. You can just stay here, and we will be now moving over to the discussion group. So I am going to turn it over to Dr. Michael Chappell, who will be leading that conversation with you all. And our two panelists will be joined by Victor Vasquez. And Mike, you can take it away from here.
Thank you, Erica, and thank you to Rebecca and Susan for some excellent presentations. We do have some questions queued up, but not many. So if folks have additional questions, now's your chance. This is really for you all to ask those sort of in the weeds type of questions about implementation and operations that may have you a little bit stuck as you think about moving forward, and hear from some of the folks here that have worked in these courts in these situations and can possibly advise. Otherwise, we'll sort of go over some of the pre-submitted questions and kind of build on the discussion a little bit, but I'd certainly rather make sure that everyone gets their burning questions answered. So we can start a little bit. There are a couple of questions in the chat, but I wanted to start with something a little bit more broad first, and I promise I will get to those questions. But maybe starting with Rebecca and then kind of moving on to Susan. We keep talking about this notion of a hybrid model, and I think what we mean generally is that some things are going to be virtual, some things are going to be in person, and we have options, and there's a lot of different ways that we can structure that. It could mean that it's certain types of services or for certain types of clients, and I think it really kind of runs across the gamut. It's not going to be one or the other. It's going to sort of occupy the middle. And I think what a lot of providers and treatment court practitioners are tripped on is sort of like, what does that hybrid model really look like? Can we provide some illustrations, perhaps, for example, looking at a hybrid approach to implementing court proceedings where you have some doing it virtually, some doing it in person? Is there an illustration that you could provide that sort of shows how we can do that seamlessly so that it's not like we're running kind of two parallel processes? Rebecca, I was wondering if you have any comments about that.
So in thinking through virtual court specifically, I think one of the things that puts our treatment courts in a unique position is that we do have different levels of compliance. We do have different phases that folks can move through. And when I think through a hybrid model, one of the things that I get excited about for treatment courts, I'm sorry, in Tennessee we call them recovery courts, but when I think about treatment courts is you could have participants that earn the opportunity through moving their way up through the phases to potentially appear virtually, or participants that have an identified employment that they can't miss, allow them to attend virtually. I think it reduces the barriers and helps our participants maintain employment and deal with childcare issues while still maintaining compliance with the court. Now, Susan's presentation was great, and when you think about virtual treatment and connecting and those important supports and relationships, we also have to keep in mind that those folks that first come into our programs, they're new in their recovery and they perhaps need more support. So when you think through a virtual court model specifically, I think treatment courts allow you to do that from a phased perspective that kind of has some parameters already built in as to who needs to appear in person versus who can appear virtually. Did I answer your question?
Yeah, I think so. And I think, and even maybe drilling down a little further, Rebecca, just,
Mhm.
the notion that, and this is my understanding, we talked about this a little last week, but I think I've been getting this question so much that it's important, is the notion that like you really can run one docket with people appearing in person and virtually. You don't
Mhm.
have to create, trying to pick, it doesn't have to be an added burden where you have these things separated and you have sort of like
Sure.
your virtual meeting and your in-person meeting. And I think that could be true for many of these types of activities where you may adopt virtually, that you may have some people participating virtually and in person at the same time by
Yes.
incorporating technology into the physical space.
Yes, absolutely. And I'll tell you, I've participated in a number of those over the past year and a half. I've been able to attend court all over the state as a participant and view in with sometimes I've been on a Zoom with participants who are joining virtually and team members who are joining virtually. And then we'll have the judge and team members and some participants that are actually, on site in person. So I think the biggest challenge to that is the technology. What system does your court have? How comfortable is your judge with technology? And that's a big piece, because when we think through treatment courts, we know the judge is the most important person there, and their interaction with that participant is key. So how comfortable is the judge in handling that and managing that? Who's there to help him do that? And Susan mentioned the lawyer cat. I know I'm a lawyer, not a cat judge. I think we've seen that. That came out of Texas. But what impressed me about that situation was how the judge handled it, because he provided technical assistance to that attorney and talked him through how to turn off the cat filter, and then court resumed. So that's another piece to think through. I mean, that was incredible. Who's going to be that person if necessary? And again, how comfortable is your judge interacting with the participants in a hybrid model? And that's a big factor to take into consideration too.
Yeah, in Mike, in New York, I think it was like about a year and a half before the pandemic started. We had a statewide project where we were incorporating using technology in some of our residential programs to allow participants to appear remotely, so they didn't have to waste the day of treatment by kind of traveling downstate or to whatever courthouse they needed to come to. And so that helped us shift pretty quickly into the virtual space. But I say that all to make the point that, we were able to incorporate and just integrate that calendar into our normal treatment calendar. So people would appear remotely on this virtual calendar if they were in residential treatment, and it was seamlessly integrated into the regular everyday docket. So it wasn't a disruption. Obviously the first appearance might have had some bumps in the road, but down the road it was just a seamless integration of using virtual technology to have people kind of appear from their treatment program, and it really just fit right into the model.
And Mike, if I
Go ahead, Victor.
Mike, and I think that it was mentioned beautifully in this presentation today, where preparation is key. You all mentioned that logging in early on time, it allows you to be able to ensure that there isn't a filter that's on, that that your Wi-Fi reception is working, that your audio is available. So ultimately, it comes down to preparation and being prepared. And of course, also suggesting to your participants, your attendees for court, that they ensure log in before the scheduled time. If court starts at 3 p.m., log in 15 minutes before. That helps you identify the attendees and making sure that everyone that was provided the link is accounted for, because you also don't want to be hacked or in some way, you don't want interruptions from individuals that are not on there. Zoom bombed is kind of the word. So preparation is key.
Mm-hmm.
Yeah, and I think I appreciate the feedback from the three of you. I mean, I think what I hear a lot of is this, this concern or this impression that it's not as seamless of a process and that it's some kind of a parallel process, and why you do need to have sort of some parallel procedures. It eventually is to be integrated as a more seamless process that, as Susan said, will probably be bumpy at first because you have to figure it out. But then once that's figured out, then it really is part of the overall process, and the calendar, largely looks the same. Um, on the same sort of note, I think treatment courts in general probably historically have more experience with the virtual delivery of treatment services, as opposed to court proceedings, which was largely thrust forward. Although Susan just gave an example of some of that work in New York and surely in other states. But I think it's the same message, right, Susan, in terms of the seamlessness of virtual services, whether it's screening and assessment, which we've seen court use, or MAT, and a lot of those are actually delivered by the treatment provider, not necessarily the court as well. And so it's just a matter of the court and the treatment provider being on the same page.
Yeah, I think a lot of that treatment, I think, I've heard many people say that if they had to plan for that, if we had to plan for this transition to virtual treatment, it would have taken years and years. But it really, the transition really happened quite quickly, and it was done very, very well. And people seem to respond well to it. With virtual treatment services, it really did seem to make life a lot easier for our participants. It removed a lot of barriers. It helped people incorporate treatment into their life a little bit easier. And as I said, it kind of helps retain them in that process because we are removing those barriers. It's not so much of a burden anymore. A lot of people would have to, rework their entire schedule in terms of when they're picking up their kids or when they're going to work. And a lot of times people had very long commutes to treatment, and treatment wasn't necessarily near their home. And so, really moving into this virtual space to allow treatment access, I think has been such a wonderful thing because it really has improved access for a lot of people.
I agree with that, Susan. And I actually wrote down a quote from Judge Ferguson out of Texas. He was the lawyer cat judge. And he made a statement that I saw when he did an interview that was very impactful. But he said, every person who needs justice, we need to ensure that every person who needs justice has the opportunity to seek it. And I really think at core, when we talk about court specifically, we need everyone to have the same access to it. And we're talking about rural areas where I know Judge Ferguson mentioned he had some individuals who had to travel, 2 hours just to get to the courthouse. And while Tennessee is not quite that far, you could be driving an hour just to get to court. And, that's a barrier. So we need to do everything we can to remove those barriers for those individuals, not just for court, but for treatment as well. We have so many we have a limited number of treatment providers, and they don't always have an office in the local county or city. So what Susan has touched on has been really, really impactful for a lot of people.
Great, thank you very much. Moving on to some of the specific questions that we did receive. There's the first question, how would we recommend for open groups that are being conducted virtually to address setting up the virtual experience with the client? I think this speaks to some of your presentation, Susan. Would it be better to set up the virtual experience in another session instead of the group session? I think what their suggestions, how do you prepare those clients? My guess would be that you're also doing individual counseling with them. You have intake, these types of procedures that if you're going to do groups, if they're not mandated and they can kind of pop in and out, that it might be cumbersome to constantly review everything with the group, as there are people who have already been participating and have heard it before. But I think it's something you do during intake for people who may be participating in groups, in individual counseling, as you express possibly the possibility of participating in groups. But any experience with that, Susan, in terms of sort of the proper forum for doing that?
Yeah, I think, Mike, as you mentioned, it can be quite burdensome to address confidentiality and privacy at every group, and that can take up quite a bit of the group. But from the very outset, when clients are coming in for that initial screening and assessment, obviously the world is different, and so that is potentially happening virtually now. And so, that's the time to begin the conversation, and then reinforced, I think, at that first individual session. And some programs have actually, drafted and have, they don't want to call them contracts, not necessarily contracts, but, some sort of confidentiality agreement that they review with participants at the first individual session, or maybe even at intake, that the participants sign to acknowledge that they understand confidentiality and privacy, and that they agree to do the things on that list, which is to protect people's privacy, maybe, and also acknowledge ways that they can protect their own privacy, like maybe not using their full name on the Zoom or on, whatever platform they're on. But having people sign that and then repeatedly just reviewing that with them throughout their participation, the duration of their participation, maybe not necessarily at every group, but throughout their participation, reviewing confidentiality, making sure there's no questions, making sure there's no changes to those policies, but really having an agreement has been helpful.
Yeah, and oftentimes clinicians, even when you are running groups, have, they do go over group norms at the beginning of a group, just like we do when we have meetings, right? Mute yourself and all this other stuff. And, I think you can certainly do that, and you can have a virtual sort of component to that, but it's a lot kind of shorter and sweeter than what you would want to review with them, more in depth. But I think one of the so to me, I think that the take home message is that it's kind of doing what you would have done. So if we were in person and this had never happened, and you have, group norms and things like that that you're going to go over in individual counseling during intake, you would continue to do that. I think one of the big mistakes I've heard it throughout sort of the past 15 months, and especially in the beginning when COVID-19, first became a thing, was that the transition was so overwhelming that programs changed everything that they were doing when they went virtually. And that just made it doubly complicated, because now they reinvented all their procedures and then had to also figure out what went virtually. And what we kept saying to people is, why don't you just continue to do what you were doing? Now, I know there are some exceptions to that, but like they changed the frequency of reporting, and they, and a lot of things. And so when you do both of that, when you change your routine procedures and then you change the medium at the same time, it can get really, overwhelming. And I think that a lot of that's what happened. And some of it was a resource issue, of course, but so I think that that's important. But to go over it with them in individual counseling and intake as sort of like, this is the kind of services you might access, these are the expectations. And then maybe have some routine reminders in group at the beginning, as you normally would, shorter.
Yeah, I think, all the group rules and the guidelines that are set for in-person groups translate to virtual. And sometimes I think it's just a reminder, when the transition first happened, I think it just kind of shook us all, even participants. And so they were kind of, like I said, joining from crazy locations, or maybe not necessarily being the most appropriate. But once we discuss, we kind of translate those guidelines for this kind of unique virtual environment, it's all the same. It's just maybe being more mindful of certain things, because it is a different environment. But all of that translates and is exactly the same. And it's just maybe adding on a bullet to the group rules in the beginning about the virtual environment, and maybe just having some reminders along the way, that all the rules still apply, even though we are in this different space, in this different environment. But it's all, like you said, it's the same. There's not a whole lot of change other than the platform with which we're using.
Right. Great. Is there any, Susan, I don't know if you know, I'm sure they exist, whether or not we have, ready access to them. Are there any copies of confidentiality waivers for virtual formats? I mean, you talked a little bit about that. What are, what are courts using? How, how in depth are they?
I have examples that I've come across just in the last year and a half of working with different programs, but I haven't seen like a standard one. All of them seem to be developed, by each different program or court.
Yeah, you would just be pulling from what courts use, and they're,
Yeah.
yeah, I mean, I suppose we could potentially, if they're open to sharing them, and if these are kind of out there, then we might be able to share with participants if folks, want to request that specifically. How about, there was a specific question about MRT, Susan, if more recognition therapy. Would you be able to explain that a little bit in more depth, or? What exactly is MRT?
Sure. So MRT, moral recognition therapy, is widely used in the criminal justice field, and it really looks at moral reasoning and decision making. And it's a series of steps, and so it's a step program that participants, and it's often participant directed, and so you provide participants with a workbook, and there's a lot of reading that they need to do, and then there's exercises that they do that correspond with the reading. And it's almost like a homework based type therapy, because the groups are process groups where then they process their homework. And so everyone, and it's an open group, so everyone can be on a different step at a different time, but they're sharing their experiences through the specific homework. And we've seen this to be really successful in the criminal justice setting, in courts in particular, and we use it a lot in New York for our courts. And so this was something that I had many conversations with Ken Robinson and the developers of MRT when we kind of shifted to this virtual world, is can we do this virtually, and how do we do it? And the answer was it translates very well, and it's very easy to do virtually, whether through the phone or through video. And so, you would hopefully have the opportunity to present a book to somebody. That's the kind of in-person handoff that has to happen. You need to provide somebody with the workbook. But then it's really, it's a self-directed, they read the pages, they complete the exercises. And it really, just like I said, focuses on moral reasoning and decision making. I think there's a lot of escaping your prison. It talks about how people make decisions. And then they can join either a group or an individual session and review their homework with the clinician. And so we found it to be, pretty effective. A lot of clinicians like it, because like I said before, it really guides the session. It provides some talking points, and provides some structure for those virtual sessions.
Do facilitators need to be trained to guide the
Yes.
process? They do.
So everyone that conducts MRT, there is a training that they need to go through and to get certified to be MRT therapist, but you don't have to be a credentialed clinician to do that. You just need to complete the MRT training.
And that's what's one of the things that's great about MRT is if you complete the training, which I did almost 20 years ago, you're credentialed forever, but you don't have to have a specific licensure level to be able to do it as long as you pass that training. And I highly recommend it. It's a great training. And I have to put a plug in here for Tennessee because it was developed in Tennessee.
Yeah, and I also should mention that there is a newly developed MRT opioid, which is really geared towards crisis intervention, that short-term, brief intervention for people who may be in the pre-contemplative phase of treatment, really getting people to maybe agree to treatment. So it's really for people that are kind of the picture perfect opioid client coming in, a much more brief type of treatment intervention that exists, and that also can be done virtually.
Yeah, and I think it would be important to note, and Susan noted this while she was presenting the information, but these are just examples of evidence-based practices for substance use disorders that can be delivered virtually. We talked about in the first session, there are synchronous and asynchronous types of interventions, synchronous being live, interactive, anything basically done. So you can pretty much take any evidence-based practice and sort of deliver it virtually, whether it's individual or group counseling. And MRT is one of those. And then you have your asynchronous interventions, which are more of your self-paced courses. CBT for CBT was an example that Susan gave. Those are more, kind of on-demand access where they can be, but they're not necessarily clinician or staff facilitated. And so they're kind of done on demand on their own time. So there's many, many, many resources out there. And many of the synchronous ones just require a video platform. And of course, it's not to say that you don't have to adapt it or think about how things may play out different virtually, whether they be exercises or whatnot. But there really isn't anything to suggest in the research that you can't make that transition to do that virtually. So there are a lot of options out there, and I think Susan's presentation talked about being aware of what many of them are. And again, really thinking about what do you do now and how can you transition that virtually, not necessarily changing everything that you do, adopting new interventions and then doing it virtually. I think that's a big, big difference. looking at some of the questions, there was an additional question while we're on the topic of MRT. Is MRT conducive to a jail setting for where individuals are sentenced but shorter periods of time? What's the duration generally look like?
It can be a short-term intervention. I know it is used in correctional settings quite regularly, quite frequently throughout the country. But it's a step program. I believe it's 16 steps, and really people can complete it in their own time. Sometimes it takes people quite a long time to get there, and other people can get through it rather quickly. If they're doing it, one step a week, you can even do it a couple steps a week. So you can pace it. If you really need to speed up the time frame, you can make it a quicker pace. But typically in the groups I've seen, it's one step a week for people to read and do the homework and process. That typically is the what they kind of recommend.
That's been my experience as well, particularly with the treatment court population. You're looking at 4 months, usually a minimum, and some clients it takes them a year. There's some steps that are difficult, and it takes them some time to work through.
Great. There was a specific question, and I'm not sure I fully understand the meaning, but there was a comment about the website used to attend court via video being blocked, something to do with the firewall, and that they'd be unable to block the website. I'm not sure what website they're referring to. Usually to attend court virtually, you're probably talking about Zoom or Microsoft Teams or one of those applications. But more generally speaking, any experience, Rebecca or Susan, with sort of like IT resistance to, some of these, the technologies that are needed or the apps that are needed to facilitate virtual or remote participation?
I haven't experienced that or heard of that being a challenge. I do know, though, as it relates to sending of information and sharing of information, sometimes treatment providers, I know, and Susan can probably speak to this better than me, but their firewalls are pretty hefty to ensure that there's the confidentiality nature of the information they're sharing. I haven't experienced it in the virtual court setting. So I would encourage you to speak with your IT person to perhaps there might be an opportunity to address that.
I'd like to say I don't certainly want to speak as someone who doesn't have experience in that specific instance or in that position, but if there's widespread buy-in and this is something that the administrative judge wants to do and something that the court wants to do, whether it's county-based, every state is organized differently, but if this is something that the court wants to do and it's coming from higher up, I would think that would probably trump or dictate what kind of workarounds IT should be looking at. There's been a lot of questions, and this isn't the first, we've had this, I think, probably in every session, so I think it's worth bringing up. What has been your experience? And I think this is one of the biggest question marks around like whether virtual or not, remote drug testing. I think a lot of people would say probably not the most ideal thing to do remotely, but maybe speak to that, but also speak to the instances where maybe it could be of value or where it is absolutely necessary, and how feasible is it in those instances?
I'll speak to treatment course specific, and Victor, I'm sure he might have some input here as well. This was the biggest hurdle that we faced back in, well, not the biggest, one of the biggest virtual hurdles we faced back when the pandemic hit and we kind of went remote, was how to do this. And I've seen a number of approaches taken. One is if you do any of the oral swab testing, that can be done, via a video conference or chat if you need to observe the testing. Another approach that a lot of our courts here have taken is that they partner with local labs that do on-site testing, so that if the court staff is not there and not able to do it, the lab personnel have the PPE, they had all of the equipment and the ability to be able to do the testing. And a number of our programs made use of that while they weren't in the office, but the labs were open. So those are two of the biggest ones that I've seen. And I know Victor probably has some similar.
Correct, Rebecca. And at first, we met several times to be able to come up with creative ideas that we'd said we still need to keep our participants accountable and to ensure that also that they are refraining from the use of any type of illegal substance or even alcohol. We also had to get creative in speaking with the third-party vendors, how you mentioned, through the labs, but also through the third-party vendors that provide the alcohol monitoring mobile device. They work off cell phone reception. Most of them, they're now considered a smart, kind of like a smartphone. We were able to order those, which became a sanction. All we would do is we would be able to receive the reports daily and the court would be able to monitor when they'd be able to get tested at random. So that became very, very effective. We also reached out to those third-party vendors to be able to include a reasonable price because they were still going to be able to be getting some type of business. Now that did increase because there was no contact. Also very important to be able to contacting local labs to creating some kind of agreement where it was going to be made affordable. I know that through our probation department, when there is a urine analysis conducted, there is a minor fee to it. So kind of what we wanted is for the labs to also be able to match that fee or something close to it, because it was also going to expand business for them, of course. So we wanted to be able to also think of other ideas, which I know that the patch is also made available, the alcohol monitoring patch. Of course, now if your courts have access to funding that would be able to pay for that for your participants, that can also be ordered. And of course, it is also a very, very effective method.
Great. Susan, anything to add, or have they covered most of it?
I think they covered most of it. And just from the treatment side of things, really when the pandemic first happened, the area that was of main concern was getting that toxicology test for MAT induction, getting that first initial test, and how do we do that? And a lot of times that oral swab that can be sent in wasn't sufficient enough because they really needed to look at levels of certain things. So that was really the concern. But now as things are opening back up, that seems to be less and less of an issue, and it's more easily accessible, going to the lab to getting that test done.
Great. And for maybe Rebecca or Victor, and of course, Susan, you're welcome to chime in. I mean, I think what we're hearing about is a lot of the steps that we're taking to get those urine tests done when we had no other options. When we do have options of in person, is there a particular scenario or client for which you think courts would consider continuing with remote drug testing, or do you think this is something that's largely going to transition back to in person in every case possible?
I would say that it largely will transition back to in-person, I would imagine. And it already has for a lot of places, although I do think what Victor mentioned as far as the alcohol monitoring, I think that's, now that we know it's there and it's a technology we can make use of if there's funding for it, I think the courts will start to explore more technology-based options, to allow for that monitoring. But when you're talking testing, I don't know that there's really any other best practice than the in-person observed urinalysis for recovery courts particularly.
Yeah, I think I think you made a mention of graduation ceremonies as well. While you can do them remotely, they're not quite as rewarding or enjoyable for everybody either. So when there's no other option and it's nothing or that, then the gesture is nice, right? But when there is the option, it doesn't seem like quite the same gesture. So I think that's important. Any record, and I'm not aware of this, but there was an additional question. Any knowledge about the use of DNA observation for urine screening through courts, or does that come up? Has anybody seen that?
For example, like as in a follicle testing, in our region, that's quite expensive. So we use that as the ultimate last resort. It has been discussed with their legal counsel, sometimes when it's been ordered, but many of the times it hasn't been, we haven't gone through it because of the expense of it. Now, of course, a lot of our participants might be indigent, or we have to take into consideration that there might be contributing members of society that are not making enough to be able to pay for something like that. And there really isn't, and not that I've heard of, a program that might be able to assist with that. But it is an expensive process. But on our side, it's used as a very, very, very last resort. And I wanted to add also that it could also be used as an incentive down the road. If once we're continuing to open up in person, urine analysis or in-person drug testing could be used as a sanction, and the virtual testing could be used as an incentive, as how they're moving along through the course of the program and through their participation. That's also something that could revisited by the courts.
Yeah, that's a good point, Victor. And I think on a related note, I think something important for many practitioners to consider is that during the pandemic, when it was not feasible for many to do drug testing as frequent or at all, or they didn't have the procedures in place or didn't trust the results from something that was done remotely. There's evidence emerging to suggest that when, if the participant understands that, a positive drug test or a self-report of drug use wouldn't necessarily be sanctioned if, as it's part of the recovery process, that people will be honest about their use. And if there's collaboration between the court and the treatment providers to address that, ongoing use in the treatment process, and it's not something that people are necessarily sanctioned for or punished for, it doesn't mean that you ignore it, but it means that you might not even need the drug testing if there's an environment of collaboration, and that's something to consider as well.
I'm glad you brought that up, Mike, because I think that is really something that we're talking a lot about in the treatment court world is, communication and that collaborative communication and establishing those connections and relationships that really allow the participants to feel free to tell the information before we don't want it to be a gotcha. We want it to be hey, I'm struggling. I need more help. Here's what's going on with me. How can, please connect me with what I need. And I really think establishing those connections is just so important.
And if I can chime in on that, Mike, just briefly, we have a motto within our court that we kind of resonate to, and that's communication. Either it makes you or breaks you. A lot of the times, what the participant is not sharing with our case manager, with our probation officer, with our service provider, is not the same. But it might not be the same information. But when we go into staffing, they need to be aware that we have this communication as a team on the court side, because they might not be being transparent. And so for us to be able to provide the best service to them is we need to really know how is it where or what areas that we are going to be able to address on their case particularly. So they need to be transparent. They need to be open with the assistance that they might need.
Yeah, and I think it's important to note again that, along those lines, that if people understand that that there aren't necessarily consequences, and that, as Rebecca put it, it's a gotcha moment, that they will be a lot more open, and oftentimes they will disclose their use. And the idea is to then bring services to bear and I know it's sort of a cultural shift, and it hasn't always been the role of justice necessarily, but treatment courts have changed that. Treatment courts have sort of bridged the perspective of treatment and recovery and justice oversight. And so, you know, we often get into sort of our deterrent stance that if we tell people they can't do something, they won't do it. But I think enough of us have worked in the field for long enough to know that that's often not true. People do all kinds of things despite consequences. And that's sort of the definition of addiction, and a substance use disorder. And so that type of a cultural shift could have a much greater impact than really ever imagined. So I just wanted to kind of change that there's been a lot of discourse around that. It's been one of the more interesting lessons learned. A lot of treatment court providers, like, you know, when we step back from that kind of approach, it's amazing how honest people have been with us. They're telling us everything about their use, and then we're bringing it back to the treatment provider, and we're addressing it through service provision.
And Mike, if I can add briefly also to that is for us within the court system, for us to be able to go back and look within the last 13, 14 months that we've been through this virtual setting, is how many times have we utilized jail sanctions as we used to prior to virtual settings? Now we are thinking about that because we don't want to have to put our participants at risk, because at some point jails became a hotspot for COVID infections, and we completely did away with that. And now it's time for us to go back and reconsider: is jail sanction still going to be a thing moving forward? So we're going to have to sit down and reevaluate that, and if it's not used at the last resort, will even be utilized at all, because the jail, of course, is not a detox facility.
Yeah, and I think, something that marked COVID in general, the period, it's not just about urine toxicology, but it has been a reduced reliance on sanctions in some instances because it was difficult to implement them, in that environment. There were too many additional consequences, one of which you're describing. I'd like to shift a little bit. There was a question about identification of peers who are working in drug court programs. If there's a sort of a way to find information for who's suited. I think, in my experience, like here in New York State as an example, there are a lot of peer certifications. There actually is one in process that's specific to justice, to criminal justice, although it won't necessarily be specific to treatment courts. But I think that's one of the challenges, is that, credentialing and certifications for peers are more broadly based, and they don't necessarily to prepare you to work in every specific setting. And I know that in our drug courts here in New York State, especially opioid courts, which Susan can probably talk to as well, there has been that translation in terms of, taking someone who's generally trained and certified and then putting them in this environment working with this population can be a challenge and require additional training or context. Have you seen any of that, Rebecca, around peers?
Yeah, I'm glad you bring that up. We have a very robust peer training system here. It actually, through my Department of Mental Health and Substance Abuse Services in Tennessee, there's a peer support training, and it's always full because there's so many individuals signing up to be peers, and it's just continuing to grow, which is fantastic. We've had conversations about how to tailor that more specifically to the recovery court setting, because it is different. I, as the statewide coordinator, have had just individual conversations with courts specifically about, okay, you have this peer support specialist. Now let's talk about what their role is, and let's talk about what their role is not, because I think both of those things are key. What you don't want to see happen is a peer to be hired to serve as a case manager. So I think having those conversations just on individual levels has really helped us, and we are talking about how to kind of add maybe an additional training component specifically for those peers who will be working with the justice involved population and recovery courts too.
Yeah, and it also depends on who employs the peers. I mean, a lot of times it's the treatment provider who employs the peers. They may make them available to do some navigation in the courts, but you know, then you have sort of like the supervision is being done by the employer. And then, you know, like unless it's a direct employee of the court, which there's a lot of discussion about that, right? Because you have an employee, you can control what they do and you can set it up the way that you want it. But that's been a big challenge too, because peers haven't really penetrated the court as much, you know, in terms of being on their payroll, as much as I've seen it more be a partnership between the treatment agency who employs the peers and then uses the peers in the court to help sort of navigate referrals and things like that.
Yeah, and I think, you know, while peers have been around for several years now, it's still such an emerging field that there's a lot to work out. And I know we're constantly in discussions about what the peers role is on the drug court team or the treatment court team. And, you know, like you talked about before, you know, providing that additional level or layer of training in terms of criminal justice and maybe court involvement, coming from the court system, so peers know, you know, what they're getting involved in, what this environment looks like, and what some of the nuances are to that environment. But I feel like there's so much to figure out still, you know, and we're kind of going through it as it happens, and, you know, learning as we go, because it's such an emerging field still.
Yeah, I mean, we've had instances where we've had agencies who are sort of like where there's peers in the treatment courts and the defense attorney is like, why is this person speaking to my client? You know, what are they talking about? What are you, don't ask questions about their, you know, like, and a lot of that is due to a lack of communication up front between the different parties, but it's also due to the fact that it's so new. Like there's no expectation of who this person is and what their role is and what they could possibly be doing there, you know, from the point of the defense attorney, for example.
Yeah, I think there's a lot of room for education, for all the court team members, even, you know, court officers and people involved, on the security end of who are these people, why are they coming into the courtroom and stepping into the well, and, you know, how are they involved, and there's a lot of room for education there about what that role is, that they are, you know, most of them are certified, they have gone through some level of credentialing, and that they are, you know, they have a designated and defined set of roles and responsibilities.
And Mike, if I can briefly add to that, also upon graduation, a mentor program can be pushed once that, you know, that these participants are leaving the program, whether they might have been there for 6 months, 12 months, or longer than that. Creating within your court a mentor program that'll be available through the court system, that you're able to offer some guidance through these mentors to new and upcoming participants of the drug court. That's something that could be implemented as well. It's also cost effective. You might not have to pay these mentors. You know, they'd be on a volunteer basis, but that could be something encouraged.
Great, thank you, Victor. This is an interesting question. I haven't really heard this one before, and I don't know the answer, but I'll throw it out there. Has anyone on the panel experienced or heard of experiences where clients have been doing treatment now maybe for over a year virtually, right? We're 15, 16 months into this. Maybe there were some of the original virtual clients, and they're now sort of missing more due to the ease of it being virtual. It almost sounds like, has there, you know, have we seen evidence of complacency or you know, kind of going through the motions? I have not read anything about that. It would be quite complex to research, but I'm just curious if there's any impressions about sort of like those have really settled into the virtual life.
No, I haven't heard of anything like that. I can't give any examples. I'm trying to think back to all the conversations I've had, but I haven't heard anything that kind of speaks to complacency. Usually if someone kind of drops off, it's more of an accessibility issue, like they lost their internet access, and you know, you have to work through some of those troubleshooting and get them back online. It's more accessibility than complacency, but yeah, I'd be interested to hear.
I think from the court's perspective, yes, there has been some of that. And that's why when I opened my presentation, it's set the rules, set the expectations, have the policies and procedures, because there are some of our clients who, when given a little room, will take a little bit more than they're given. And so if you address it on the front end, all right, here's the expectation. You have virtual court or you have in-person court. Here's the circumstances. You get to do this or you get to do that. Certainly you don't want to sanction a participant if there is technology accessibility issues. Have a policy about that. If your phone isn't working, or if you're not going to be in an area that has good coverage, or whatever the what ifs that could be, if you think through those things and you're able to say, okay, if you cannot access, here's what you do, then that can kind of help address some of that on the front end, rather than being caught in a position where, well, they sent me a picture of a flat tire, so maybe they had one. I don't really know. Did they Google it and send it to me? So I've had that happen. So you just want to kind of, if you can address some of that on the front end, I think that's where there's real value in that.
Yeah.
Victor, I know you've not seen any of that.
We haven't yet. I think that the best scenario I can talk about is to reeling them back in. Kind of make it a little bit more interesting for them. So what we tend to have is at least quarterly have some kind of a Q&A session that includes everyone, even if they're doing well or not. Bring everybody into the well of the court, do a Q&A session, and have to hear from them, communicate with them. That's why every time that we have some kind of communication with them, like an office visit or something, we want to be able to ensure that that they're still working. If they don't have internet access at their home, we encourage them that they might go to public areas that provide Wi-Fi that they could take advantage of. If they don't have a working line, encourage them to get like a Google number, through WhatsApp or anything like that. That we're able to work with them, but we need to keep them still accountable and being able to remind them of that.
Yeah, I think that's really important. There was an additional comment and related to that there's, people have struggled to plan virtual sessions because they don't have to be in the location. They could really do it from anywhere, right? They could be out and they could be shopping or doing something else, and they might forget that with the limited structure, it makes it harder for people to plan their schedules appropriately. And I think we've seen that in general with a lot of people. I see it with my kids around school. They're sitting at home next to their Xboxes while they're on computers. And my son is playing Xbox at 1 PM, and I'm going, wait a second, you're done? Yeah, I'm done with all my work. No, you're not. There's proof. It's a lot easier to kind of lose sight of our schedules. And I think there's a couple of things there. Some of it may be that they shouldn't be participating from some of these places if they don't have to, right? They may be there for Wi-Fi or what else. But I think also, one thing that's proven to be maybe not necessarily for this, but a series of text reminders and systems. I don't know if any courts in Tennessee or Texas or New York are using text reminders for all their appointments, but just trying to help people sort of stay on top of their calendars, virtually or not, I think would be very effective. And I know many treatment courts that have done that. Just to make sure that they don't, it's true. It is a little easier to slip, and trying to help them not slip.
And Mike, if I can add to that, I know that in the very beginning of it, as we were scrambling to kind of come up with what is it that we're missing. So it was basically learning as we go. Something that Judge Villarreal from our court implemented was that as we sent out this notices of the link for them to log in, there's a small portion that we included on there. Remember that act like as you are in court because you are in court. No cap. Don't be driving while you're in the court proceeding. Please have a respectful background. Please have enough lighting. Because we were able to, and we kept on adding as we met weekly, because we kept learning as we went. So that's also very important, is when we're communicating with them, if it's going to be a virtual setting, making sure that we list it on there when we send it out, kind of as a warning. And also when we have the court proceeding going on, if we might see something that is inappropriate or anything like that, we can completely shut off their video and just address them through audio only.
Right. So you don't necessarily have to be in the court, because that's not possible, but you really shouldn't be just anywhere. we're not sort of like second fiddle in terms of, sure, log in while you're, while you're grocery shopping, or, trying, when avoidable, right? When avoidable. So it's 2:59. I think we got to most of the questions, and rather than open it up, I'll be respectful of everybody's time. This is the third and final session of this virtual learning community. I know that there's a lot still to happen. I'm reading about increases in cases of COVID across the US due to the Delta variant, reading about other things that suggest panic, that we might be going backwards. So it's very hard to determine how forward are we going, at what pace, but I think everyone's in a little bit of a different place with this as well. And so I wish everyone luck. I hope this series was incredibly helpful to help you think through some of the challenges, and at least give you some of the context as you do think about, what things might look like more permanently, and take the time to sort of make those adaptations. I hope everyone, again, enjoyed this series, and hopefully we'll see you in the next series. And thank you again to Susan, Rebecca, Victor, Erica for your support, and everyone else for attending.
Thank you all.
Thank you.
Thank you all very much.